Welcome to the Attention Deficit Disorder Expert Podcast Series by Attitude Magazine.
Hello, everyone. I'm Carol Fleck, and on behalf of the Attitude team, I'm pleased to welcome you to today's ADHD Experts presentation titled, For Clinicians, Common Treatment Barriers for Patients with Depression and Trauma. Leading today's presentation is Dr. Lawrence Amsel. Dr. Amsel has worked at the intersection of psychiatry and physical medicine throughout his career. He was a hospital and emergency room psychiatrist for more than 30 years. For the last decade, Dr. Amsel has worked at the Reach Institute, where he helped develop a program that integrates mental health into primary care practice. As many of you know, the Reach Institute trains providers in the latest evidence-based therapies to diagnose and treat mental health disorders in children. Depression is among the most common of mental health disorders. While routine screenings for depression are becoming more common, many people still go undiagnosed and untreated. In today's webinar, our expert will discuss best practices to help providers improve communication, engagement, and outcomes for patients with depression and their families. We'd like to begin today's webinar by asking this poll question to our live audience. What strategy has helped your patients open up more to reveal their feelings and stick to their treatment plan? Please add your comments in the text box under the video player. For answers to common webinar questions about slides, transcripts, and certificates of attendance, click on the FAQ tab of your webinar screen. If you're listening in replay or podcast mode, visit attitudemag.com and search podcast 471 to access the webinar resources, or simply click on the episode description wherever you stream your podcasts. If you support the work we're doing here at Attitude to strengthen the ADHD community, we encourage you to visit attitudemag.com/subscribe and sign up for Attitude Magazine. The new fall issue is out now, and it's full of great advice for your patients and for families and adults touched by ADHD. Click the magazine tab on screen to learn more. So without further ado, I'm so pleased to welcome Dr. Lawrence Amsel. Thank you so much for joining us today and for leading this discussion.
So it comes over to me. Hi, everybody. I was always told by people that, there's an extra special pressure on a presenter when the presenter is talking about communication skills. And then if they don't do a good job and they say, that guy is teaching communication skills. So there's that extra pressure. Here's the communication skills in primary slide, which is what you already went over, which is the what Reach Institute does. And again, helping with training primary care clinicians of all kinds to be better at doing mental health, since we know that primary care clinicians actually supply about 80% of the mental health care in this country. So the goal of Reach is to help them do a better job of that. Well, we're going to talk about communications, and in particular, when you have patients who have depression, trauma, or ADHD, each of these disorders confers communication challenges. Each of these disorders makes it so much more difficult for the client or patient, whichever you prefer, to call the person you're working with, to communicate in an easygoing way. One of the reasons for this is trust can be quite an issue in any of these disorders. Obviously, in trauma, trust is a big issue, but in depression, trust is also a big issue. And in ADHD, trust is also usually a big issue, because a lot of kids and young adults and even older adults who have ADHD and have had ADHD have so often run into conflicts with teachers and bosses and people who have authority over them, because their difficulties, their struggles with concentration have been, rather than dealt with in a sympathetic way, but have been critiqued. They have often been said, oh, you're so talented, but you're lazy. So a lot of times as well, people with ADHD do have some trust issues when it comes to dealing with teachers, dealing with professionals. So in each of these, the ability to understand the medical information is therefore compromised by this communication barrier. So it's so great that you guys have come here to try to learn better communication skills. And our last point I wanted to make is that individuals with ADHD are 3 times more likely to suffer from depression. And this is for the reasons I've already said, because they get so much negative feedback from the world, both from humans who give them a lot of feedback, and also when they're facing a task and they're unable to accomplish that task, there's a tremendous amount of frustration that people with ADHD have. And so I think that sets them up for a greater amount of depression. And as a lot of you who may have been treating people with ADHD will know, that you've got to be on the watch out for that and to be able to sort out what is the chronic ADHD and what's the depression. So the best communication, so starting with communication, I just want to share a personal anecdote, which is the best communication advice I ever received. And this was someone who was, when I was an intern, we had one of the senior attendings who would be rounding with us on patients. And he said the following. He said, when you only have 1 minute to spend with a patient, don't spend that minute leaving. And what this meant was that we all have the tendency, when you have a short amount of time with somebody, we all have, we're always thinking about the next thing. We're thinking about the fact that we have to leave. And so we come in and we say, well, I only have a minute and I'm sorry, but I'm going to have to. And that's, you're spending half of your minute leaving rather than staying there. And he demonstrated how he could walk into a patient room, not focus on leaving, but focus on being there and being absolutely present and for an entire minute, and how it felt like a effective communication, an effective visit. It didn't feel, strangely, as short as a minute. So when you're really present with somebody, a minute can be a long time if you use it properly. So in thinking about communications, I want to think about a Cartesian plate, right? The old XY axis. Remember, abscissa and ordinate. I don't know how you learned it when you were in K through 12, but here it is. It's a plane, and on the x-axis, it goes from nonverbal communications to verbal communications. And we are all, as human beings, incredibly good. We have fantastic radar on picking up nonverbal communications. We have very, very good radar about that. Unfortunately, the verbal communication is the one that tends to dominate. We tend to think logically and listen to the patient's words, although our own body and our own I'm going to use the word unconscious, but it's not the perfect word for it. But unconsciously, we are picking up nonverbals. No matter what words of a patient has, you kind of know whether the patient is tense, angry, cooperative. You get that feeling from the nonverbal. So it's important to understand that nonverbals and verbals are on a continuum. On another continuum is facts versus emotions. I want us to be clear that we usually think of emotions as the nonverbal and facts as the verbal, but actually all 4 quadrants are possible. So, for example, here the quadrant of a nonverbal fact. Well, a nonverbal fact, which is like this sort of gait and posture, the way the patient walks, the way they move, the way they talk, that's nonverbal communication, but it is about a fact, not about an emotion. On the other hand, a facial expression is a nonverbal communication, which is about an emotion. So that goes into this quadrant. On the other side of it, when it comes to verbal things, facts like a discussion with an accountant, that's not much of an emotion. So that goes in this quadrant. It's not an emotional discussion. It's a logical discussion, and it's verbal. But I can also have verbal communication, like a heart-to-heart talk, which is not about nonverbal communication, but it's verbal communication and it's emotional. So there are these 4 different kinds of communications: nonverbal facts, nonverbal emotions, verbal facts, verbal emotions. And if you think about those, you can become more aware of where you are at any given moment in communicating with somebody. And when I say where you are, I mean where your attention is, because all 4 are going on all the time. All 4 are going on all the time. Now, that pause was on purpose. And I want you to know that even a tiny little pause on that, was a nonverbal communication. And even for that short period of time, you pick up on that. What's that silence? What's going on? Did the computer turn off? Did Dr. Amsel freeze? So I just wanted to sort of demonstrate a tiny little example of your very quick radar on a nonverbal communication. Okay, so what are the skills that we're going to discuss? When I came through my training, and I wonder probably the same for you, two of the things that people always told me that drove me crazy because I didn't know how to do it was, one thing they said is use open-ended questions. I said, how do I do that? I don't know. They just said use open-ended questions, but nobody ever gave me a technique. The other thing they always said was you have to be empathic. You have to be empathic. Well, they taught me all the other skills. They taught me how to take blood pressure. They taught me how to do a physical exam, but no one ever taught me how to be empathic or how to demonstrate empathy. So it's rare that anybody gets any training on how do you do these things. What do I mean by it? So we're going to try to cover that. A lot to cover in a short period of time, but at least give you an introduction to these two things. So how are we going to address those? We're going to address those by focusing on how to create open-ended questions and by teaching you active listening. Active listening is hearing a person's needs. I want to emphasize that word. Think about needs. What's the person's needs underneath the spoken word? And if you do these two, then it will lead to empathy, and that is experiencing the need of the patient. So those are the skills that we're going to focus on right now. So first thing is, how do you change a closed question, which is a yes-no question, to an open question? And to shift the question from closed to open, use two simple steps. Step one is identify the topic of interest in the closed question. Identify the topic of interest in the closed question. And step two is thinking about that category of what it is. Invite the patient to tell you about this topic. Invite the patient to tell you about this topic using some of these open phrases. I would actually write these down or have them, kind of in a little brain toolbox, right? What is your experience with? How is? Can you help me understand? How is that affected? What did you imagine caused this? Okay, so let me give you a quick example of this. Do you spend time with friends? That's a yes-no question. You might be asking a physician or a clinician, nurse practitioner, or a social worker might be asking an adolescent who seems depressed, might be asking this question to ascertain things about that child's depression. So you might ask the question, do you spend time with friends? Trouble is that's a yes-no question. The person could say yes, no, and that's the end of the conversation, especially, again, with a depressed patient who's just going to want to move on. So what is the topic in this question? The topic is social activity. So step one is identify social activity. I then just attach, remember, those beginning sentences to this, and I say, tell me about your friends and your activities together. Tell me about your social life. Okay, so you see, that's an open-ended question. It can't be answered with a yes or no. It invites conversation. So how you ask a question can influence the patient's answer more than what you ask. Here are some closed questions. Are you taking your medication daily? First of all, puts a person on the defensive, right? Do you smoke? Do you exercise? These are yes-no questions. Have you ever seen a therapist? Do you have side effects with new medications? Now, we need this information, so we often will ask these kinds of questions. But how can I do better with these? Okay, let's start with the first one. Are you taking your medications daily? What's it about? It's about taking medications. Okay, so then what is your experience with taking your medications? What is your experience with taking your medications? It's very much less judgmental. It's an open-ended question and allows the person to give you an answer. Do you smoke? Tell me about your smoking experience. Again, what am I identifying? Smoking experience. Tell me about. I just put the tell me about in front of it. Do you exercise? What's it about? It's about exercise. So I put one of those starter phrases in the beginning. What's your attitude? What's your experience? What's your life experience towards regular exercise? What is your attitude? Right? Completely takes the judgment away opens up the dialogue and gives the person. I think this you see how this goes from a kind of a disrespectful or kind of a judgmental to a very open question, inviting conversation. Have you ever seen a therapist? Well, that's tricky with people, right? Because people, that implies that I think I should have. So here goes. What are your thoughts about seeing a therapist? Have you ever thought about seeing a therapist? Tell me, is closed. But what are your thoughts about seeing a therapist? What's your attitude towards psychotherapy? What do you believe about that? See, a lot of people that you'll encounter will say, I don't believe in psychotherapy. Well, if you ask them, have you ever seen a therapist? You're not going to get that information. But if you ask the whole question, what are your thoughts about that? What are your beliefs about that? And people say, well, I've never seen a therapist because I think it's bullshit. I think it's nonsense. Well, good. Then you have a conversation. You've opened up the conversation and you've gotten them to tell you their real thought instead of their hiding. Do you have side effects with new medications, right? Again, what is it about? It's about side effects. Tell me about your experience with side effects. So I don't want to belabor these. I think that those were enough examples for you guys to get in a little practice. And what I advise is that you actually practice this. You know, think of 10. Think of your own interviews. Think of 10 close-ended questions you ask and practice how to turn them into open. If you practice a little bit, this becomes really automatic and you can do it in seconds in your own head. All right. So we talked about the first thing, which was that I'm told to do open-ended questions, but not given a technique. And I hope I've given you a quick technique for working with that. But what about achieving empathy? Well, the answer is this thing called active listening, right? And active listening is hearing the person's needs underneath the spoken word. See, one of the things we tend to do is we tend to listen very concretely to what the person says and to answer the person logically. That's certainly what we do in the office. By the way, it's not what you do in your relationships, because in your relationships, think of your spouse or think of your boyfriend or girlfriend or think of your child or think of your mother. When you listen to them, you're not listening for facts so much. Or think of a small child. You're not listening for facts. You're listening for the emotion underneath. And again, that could be verbal or nonverbal, right? So when you're focusing, what active listening is a technique for getting you to focus on the needs that are underneath. And then in that model, empathy gets a better definition. It's experiencing the needs and story and the point of view of the other of the patient. So it's experiencing it and being able to communicate that you experienced it. Experiencing it, being able to communicate that you experienced it by not focusing on the superficial, on the words. They may not be superficial, but not focusing on the surface words, but on the need that's underneath. And again, doing that is not a new skill. It's just bringing a skill from your personal life into your professional life because you have that skill already. But I promised you that I wouldn't just tell you to be empathic. I'd give you techniques, just like I gave you a technique. So I'm going to give you some quick techniques. And this comes out of something called the LEAP model. And the LEAP model is a modified motivational interviewing, an approach for active listening. Some of you may be familiar with the notion of motivational interviewing, a whole technique that was developed and tested for substance abuse and has been very, very effective in substance abuse and many other things. I'm not teaching motivational interviewing. I'm just stealing some ideas from motivational interviewing, but it's actually a wonderful therapeutic technique, and we're going to borrow some of the things that it uses, and we're going to borrow them through this acronym of LEAP. And LEAP will stand for listen, empathize, educate, and exchange. So the E has three meanings: agree, partner, plan, and proceed. So the P also has a couple of meanings. Now, I want to block all of these out, and I want to point out that as clinicians, when we tend to talk to people, we are focused so heavily on the planning and proceeding. When we ask questions, we're immediately thinking about what is my treatment plan going to be? What am I going to do for the patient? How do I respond? And I'm going right to the plan and proceed. I'm trying to come up with a plan. I'm focused on that. And when I am focused on that, I can't be really listening to the patient in real time because I'm focusing on the next step. And so then we wonder why patients are non-adherent. Well, because we went right to the plan and proceed. We didn't get them on our side. We didn't get on their side. And we do. Now, this is natural because that's your job. Your job is to come up with a treatment plan and to proceed with a treatment plan. But the idea here is to take a pause and not go to that. There used to be an old Red Cross saying, which was, in case of emergency, don't just do something, stand there. Don't just do something, stand there. In other words, take the time to think through what's important before you act. So let's go through each of these, the steps of this acronym individually. The first one is LEAP, is having to do with listening. Well, what do we mean by listening? We have active listening. How do patients listen? How long? So let's take a think of how things are now. How long do clinicians listen to patients' initial presentation? The answer is that research has shown that there's different research on this, and I put a couple of papers down here if you want to get these references and read them. But there's a lot of research that shows that it's about 11 seconds, right? That clinicians will say, this is especially true for primary care clinicians. Unfortunately, we have very little time, or for a cardiologist, say, well, tell me what the problem is, and they will listen for 11 seconds before interrupting. So that is not active listening. So how do you do the active listening? How do you do that? Well, first of all, you don't interrupt in 11 seconds, right? Know your quadrant. Listen for needs, okay? And watch for the nonverbals. Focus on their perspective and especially their needs in the moment. So you say to yourself, I'm going to put aside my plan. I'm not going to get to my plan yet. What I'm going to focus on is, what is this person's need in the moment? What do they need in the moment? And I just, from life, a great example from life is just a baby crying. Right? I mean, those of you who are parents or who have nephews or nieces or little children in your life, when you have a little baby that's crying, right, can't verbalize its needs, really we spend a lot of time trying to figure out, oh, what is it? What is the need that's being expressed here, right? And so use that example about active listening. You're really actively listening to that cry and trying to figure it out. Ask yourself, what does this person want me to hear? What do they want me to believe? What do they want me to understand about them? And try to see the problems from the patient perspective, not the clinical one. You know, we're often trapped in a thing that we know a whole lot about a particular disorder, about a particular problem. The patient doesn't, and we're trying to quickly get them to be as wise as us. You know, I know the answer. But if you start from that perspective, you're just going to get pushback. So the idea is, no, don't start from where I am, my knowledge and wisdom. It's start from where they are. All good teaching, start from where they are. Now, here's the important thing about empathy that's often not told, which is that the most important thing about clinical empathy is not how you feel, but what you communicate, that you let them know that you're understanding, that you give them a signal that you're listening. Okay, because if you're very empathic and say, oh my God, I really feel this patient's pain, I know the pain and stuff like that, and you're silent about it, or you lock it up, which is the way some of us were trained, by the way, then they don't understand that you understand. And if they don't understand that you understand, you haven't communicated, right? Because communication is getting you both to understand the same thing. So here's a great rule. When you're listening to a patient, don't do anything else. Don't plan. Don't think about what's for dinner. Don't do anything else. Don't even worry about what your response will be. If you're listening carefully, it will come automatically. Your responses will come automatically. And as I'm going to show you, the plan will happen very easily as well. So just listen. Allow yourself to feel the feeling. Now, this doesn't mean that you have to feel people's pain. I do a lot of trauma work, and I have to train people in trauma work, and people are always afraid, am I going to get traumatized? And I always say, to some extent, people do. Obviously, clinicians who work with trauma can get somewhat traumatized, but you can really minimize that if you understand that your job in empathy is not to feel bad. It's to understand the patient's feeling. You don't need to, and this feels a little bit confusing, but you don't need to feel the sadness. You need to feel the fact that the patient is sad. Again, you don't need to feel the sadness. Clinton used to say, I feel your pain. That is not empathy, okay? And it's also not possible. What you want to do is you want to minimize your own depression and anxiety and things like this when working with patients. So you don't have to feel the sadness. You have to feel the fact that the patient has that sadness. You have to be there with their thing. Doesn't mean you have to you have to take it in as a painful thing. So heartstrings harmonics means that I use my radar for emotions to be aware of the other person's pain. It doesn't mean that I have to experience the pain myself. That's a subtle but important point, and I hope I've managed to communicate it. If I haven't, we can go back to it in the Q&A. Now, once you've been able to understand where the patient's coming from, identify and restate in your own words what they said. And you can, if possible, even not only what they said, but what the feeling has been. And after you've been able to restate that to them, then you can say, okay, what's that been like for you? Let's dig in the next slide. So again, there are these opening sentence phrases that you should have in a toolbox, right? So you're saying that you're not convinced that I can help you, for example. Or it sounds like, in addition to your child's school problems, you've been feeling isolated. Or I get the feeling you're wondering if we need to begin to think about end-of-life issues. Okay? I hear you saying. See, so all of these are great openings, and these are ways of opening up the back communication, right? The active listening part where you are communicating back to the person, back to the client patient, that you understand them. Let's look at some subtypes, what we can do in this. There are actually different kinds of verbal responses. And you don't have to worry about the categories, but it's just interesting to understand that the kinds of feedback that you give can be put into certain categories. One is reflecting, which like a mirror reflecting. It sounds like you're concerned about this, right? So that's straight reflecting. Normalizing is saying something like anyone would feel scared. Normalizing is also used, by the way, in open-ended questions. Sometimes before you ask an opening question, you will normalize it, which means to say you let the person know that this is normal. So, for example, if you're a pediatrician, you're working with adolescents, you might say, many of my patients vape. What's your experience with vaping? So I first normalize it. Many of my patients vape, right? So that's a kind of normalizing feedback. Self-disclosure, something like, we never seem to stop worrying about our kids. So that's what you kind of share. You give the feedback that you're sharing. Highlight and amplify, which is, I'm impressed by how well you've communicated how sad you're feeling. I'm impressed by how well you think. And partnering, which is, you could say, we can figure this out together. Okay, so all of those are ways of communicating after you have listened very closely. The active listening part is communicating that you have managed to understand their need. You have managed to understand their need, and you're letting them know. Now, by the way, when you do let them know, here are your nonverbals that can go into this. Be aware of them. Now, some clinicians like a very, very flat affect and a very flat communication style. And this used to be when I was training, that's the way they taught us is, just, sort of be a robot. But we don't advise that. If you're going to communicate, be aware of your voice quality, tone, the volume of it. See how different that feels? If I just even for a second, okay? Eye contact and facial expression. You want. And by the way, this is nothing about faking it. This is just about being genuine, but being aware of, your eye contact and your facial expression. Eye contact, especially these days when we're also doing our electronic medical records at the same time as we're talking to the patient. So eye contact is important. Look up from the screen, look up from the piece of paper, look at the person, especially when you're saying back to them. If you're looking down at your computer and you're saying, and you're giving them active listening feedback and you're saying, from what you said, I understand that you've been feeling very, very depressed about your relationship. And if you say that while you're looking down, as I'm doing now, that is not going to work, right? You've got to stop, make eye contact, and let the person know that you are present, okay? Unhurried, use pauses when necessary. Have an open posture. Now, sometimes And it depends very, very much. This is controversial, but sometimes touch, like just a very, very light touch when someone's telling you, for example, if someone's just lost a parent or something and you might touch them, be aware that that's sometimes an option, sometimes appropriate, sometimes not. Sometimes it's very socially awkward not to do it in certain very intense situations. Okay, so that was the listening part. Now let's go to the E part, which is to exchange. That's exchanging information and asking people, let's share some information now. Not a one-way, but a two-way sharing of information. I've understood your need. I've understand what your problem is. How do we start exchanging information about that? What would work for you? How might we do this? Share your ideas. Ask them for ideas. So that is the exchange part. Now, again, you've got to do this in order. You're not going to be able to get to a free exchange if you haven't communicated to them that you really heard their need. But once you heard their need, people really open up when they experience you as having heard their need, and then they will exchange information and allow you to exchange information. And the E also stands for engage, educate, encourage, all of these kinds of next step things that come after you have demonstrated that you're listening. Be aware of some basic needs that everyone has. Everyone has the need to feel loved, to be important to someone, to be good at something, to belong also to a group, in addition to individual relationships, to belong to a group of support of some kind of community. And in order to achieve these things, everyone has to be part of a village. It takes a village for all people's basic needs to be met. But these are the kinds of needs. If you think of these basic needs, it is also helpful because these are the categories in which, when needs are not being met, you'll get depression, you'll get anxiety when these needs are not being met. So thinking about these needs is very, very helpful in this exchange. Oh, I hear that you are feeling isolated and that no one cares about you right now. You're just being so isolated. So that will map onto the need to feel loved, the need to feel important. Also is something that you, again, these are the categories of needs to be aware of and to be able to exchange information about how is it going in those particular need areas. Okay. Now, once you have done that, you've exchanged information. Now you can start the negotiating process. And by that, I mean being able to do things together, getting to agreement. And as many of you know, that's the hardest part, right? And one of the things that's frustrating for clinicians is, I have a perfect plan for this person. Why isn't he listening? Why isn't he adherent? We used to say compliant. Now we say adherent. Why isn't he adherent? Why isn't he listening to me? Well, that's because you haven't gone through these steps where you've won them over. And once you've won them over and you've exchanged information and you are in that collaborative mode, then you can have agreement, right? You emphasize, I can't do this without you. I need you to partner. Not I'm telling you what to do and you have to do it, but that this is a partnership. And think of the patient or the client as your most important team member. They're your most important team members. So I need you on board with this. And sometimes that means you're going to have to compromise your plan. The plan is going to have to be something that's realistic for this particular individual. It's not what you think was ideal. It's what's ideal given this person's beliefs, limitations, etc. So that's the agree part. And then when you have the agree part, only after you have these three things, you've done your active listening and your empathy, you've done your exchange, you've done your agreement. When you have done that, then you're in a position, and you know what you've already had an agreement discussion. Then you can say, okay, we can lay out this plan. Here is the plan of what we're going to do. Now you're going to have much more buy-in to that plan, right? So mentor and support the patient to build their own long advocacy thing. Gather essential elements needed for the patient to be able to do this, okay? Do ongoing problem solving. Let the patient know that you'll be there. This is not our last meeting. Here's the plan I have based on what you told me about yourself. Here's my plan. And I am available for us to change this plan, modify it for you to tell me what problems you would have in your carrying out the plan. So that's part of putting a plan together, but also being a partner, so important. So in summary, listen, ask about their view of the problem, avoid parental blame or lecturing, empathize, engage, and encourage, allow yourself to feel their needs, express your understanding to them, recognize their efforts and the challenges they face. Turn your radar on for shame and stigma, because if they have shame and stigma, it is if you sense shame or stigma, it'll be harder for them to open up. Now, sometimes what happens when we experience through nonverbals, usually, that the patient is feeling shamed or stigmatized, we shut down because their shame and stigma makes us, okay, I better shut up, or I got to move away. We have a natural human tendency to move away from that negative emotion in the room. But that's the wrong response. The right response is to very openly feedback and say, I have a sense that you're feeling uncomfortable or feeling some shame. Is there something I said? Is there something in your life situation right now? I have a sense that you're feeling this. Okay, rather than what is sometimes our automatic response of moving away from the emotion. Then you can come to agreement, and then you can come to partnership and planning with a patient. So you can enhance the patient's support, build their advocacy skills. Multiple problems require multiple solutions, and medication alone, for those of you who are prescribers, I know I don't need to say this to you, but it's important to emphasize that even many psychiatric illnesses, such as moderate, not severe anxiety and depression, but moderate anxiety and depression, don't even need medication. They need forms of psychotherapy. And lastly, which is maybe the most important thing of all of this, is I cannot do this without you. I cannot do this without you. So it's a wonderful phrase because it creates a partnership. It says, I may be a clinician, but I'm not God. Don't make me God. Okay? And I'm not God, and I'm not going to tell you what the right thing is. I'm going to listen to you. We're going to be partners. You give up some of your own power. I can't do this. In exchange for partnership. Give up power in exchange for partnership. Let's see, I think this one. So just to close, here are some things that patients have told us that they really helps them when they hear this from a clinician. There's hope for your future despite these problems. So let people know. Don't assume. Sometimes patients come in and they have a problem and you know it's going to get better. They don't. Okay. You're not alone in dealing with the problem. So loneliness, despair, these are things that they might be feeling. So address them. Your illness is not your fault. A lot of times people think that their illness is a fault. Or for example, parents think that the kid has ADHD. They think, oh, I did something wrong. I understand what you are saying and dealing with. I understand what you're saying and dealing with. Patients really are moved when they hear that. Okay. And you have many strengths. So when you're talking to a patient about, okay, I'm going to have to give you a diagnosis of depression, it feels debilitating. So make sure that you also focus on their many strengths. Okay. And then don't make comments. Be aware of sometimes we don't intend to, but our comments come across as blaming or dismissive. I know that no clinicians are intending to do that, but be aware of the way that you sound to others. Now, what happens if you use these steps in order and actually apply them? First thing I want to say is it probably takes a little bit longer, but not as much longer as you might think. Remember we talked about the 1 minute thing? I'm not saying you can do anything in 1 minute. You can do this in 1 minute. There is a lot. You can be present in 1 minute. You can't do all of this in 1 minute. But as far as time is concerned, this is actually efficient because if you get the patient's understanding, the patient joins you, you save a lot of time in follow-up. You save a lot of time with arguments, with non-adherence, with future problems. So it is a little bit of an investment of time ahead of time, but it ultimately has been shown that it saves time. You've all had experiences in your life where a very short conversation has changed things, right? A very profound conversation has actually changed something in your life, right? So it's not so much about time, but do be willing to give this a little extra time from what you might have previously. And sometimes that involves, if you're going to have for example, if you're in a primary care setting and you have a mental health patient, schedule a little extra time if that's possible. Have the people, or break it up into 2 sessions and say, I'm going to see you again next week and we're going to continue this conversation when it's not an emergency, of course. So either break it up into multiple sessions, schedule a little bit more time, but also just recognize that what sounds like it takes a long time does not really take that long. By the way, speaking of time, I told you that usually patients are interrupted in a clinical setting, not a psychiatric or mental health or social work setting, but in a medical setting, usually in 11 seconds or shorter. They also did research on what happens if you let a patient run and tell you his whole story. People are fearful it's going to take hours. No, it takes about 2 minutes, usually 2 minutes for a patient to be able to describe their distress. So that's not that long either. So what happens if you do this? There's greater understanding of the problem, both by yourself and by the patient. Patients feel listened to, patients feel listened to. All the difference they go, patients' assessment of excellence in a clinician. Sometimes it's not by their technical excellence or, they know 14 different alternative drugs to use for this. But it's often in that skill of being listened to. It occurs to me that I've never said this before, so I'm trying out new material on you guys now today, which is, if you're aware that in an interview that you're doing with a patient, we think we're asking the patient questions, but you're actually in a job interview. You're in a job interview. The patient is trying to figure out whether to trust you or not. So you're in a job interview in that thing. And if you think of it that way, and you take the skills that you have from, and given that you're working, you've gotten your degrees, et cetera, you must have some skills at job interviewing. Bring some of those skills in. So let's go on with the slide. They're more likely to trust your recommendations. So, the patient the next day is thinking, I hate taking medication, but that nurse was so good and she said I should take it, so I think I'm going to take it, and you get better adherence. You also reduce the patient's anxiety. Why? Why does their anxiety go down? Why does the child's anxiety go down when they run to mom? When they see a scary dog and they run to mom, right? Cling on to mom's skirt. Anxiety goes down because this is safe space. This is safe. I have a protector. When the patient trusts you, it reduces their anxiety. You have a partner in the world. They feel there's someone taking care of them. But if they're not children, they also need shared decision making. So you can't misuse that trust and impose your decision making. You have to allow them into the decision making process. Hey doc, I don't want to take an antidepressant. I'm scared of medication. Okay. Well, there are psychotherapies that might work for your problem, and I wonder if we could make a deal so that you try one of these psychotherapies, you try it honestly for 10 weeks, and if that doesn't help, then you're willing to reopen up the discussion. What do you think about that? Well, I'm not sure, but let me think about it. So share decision making, right? Working together to come up with things that you can both believe in. And that ends my formal presentation. And thank you so much for your attention. Thank you for listening. I was going to say for listening and for your attention. And I appreciate your taking time out of your busy busy schedule, busy life to participate in this learning experience. I hope that was helpful so far, and let's get some questions and answers.
Thank you so much, Dr. Amsel. It's amazing how just slightly tweaking the way you ask a patient a question, such as about exercise, for example, or how taking a pause can have such a big impact. That was really interesting. We also have some very interesting questions from today's listeners, so let's get right to it. How can providers and families get through to a student who doesn't recognize his symptoms of depression or follow through with recommendations for coping?
So the corollary of this whole talk, remember, was that you want to let the person believe that they're being listened to. And so the answer to that question is that often, I wouldn't say most, but very often in times when you're in that situation, you get into a debate mode in your own head. I've got to convince this kid he has depression. I've got to convince them that they have depression. And that won't work, because if the kid doesn't feel that they have depression and they're fighting back against that, you're trying to convince them. You're being in convincing mode will backfire. So abandon your agenda. Paradoxically, abandon your agenda and sit down with that individual and say, what's going on with you? What is your experience? What do you believe? Instead of trying to convince them, and this is hard, because you say, but I am trying to convince them. I got kid's depressed. I got to get them into treatment. Yeah, but if you take that approach with a kid, it won't work. So abandon your agenda. Say, I'm going to put my agenda aside. Let me sit with this young person and just try to understand where they are at, what they're experiencing, what's going on with you. What is your experience right now? What are you thinking? What do you believe? What's your life like right now? And then when they tell you something about that, again, don't jump in and say, see, I told you those are signs of depression. No. So you say, oh, wow, I didn't know you. That was your feeling. That's really interesting. Have that conversation. And then you have moved things forward, because you at least now you're not the person to push back against. You're the person to trust, openness. You get some opening. It may take a couple of conversations. It may take a little while. But if you take that attitude, you at least will have a more open conversation and an ability to get to exchange. Remember, so you then follow the leap. I listen for what you have to say. I feed back to you that your perspective on this is important. I hear you. You don't think that you have depression, right? People are trying to sell you depression, but you don't think that you have that. What is your experience? Okay, you think this is that. I hear that. I understand that. And once you get to that point, then you can get to the exchange, and you can sort of say, well, I think about it a little bit differently. I really respect your perspective. I think about it a little bit differently. And again, I think about it differently. Not, let me tell you God's truth. Okay. But I think about it differently, and I wonder if you might consider some of my ideas as well, but only after you have listened to theirs.
Okay. Someone writes, I'm the first.
I just want to say, some people will hear that answer and say, but that doesn't really solve it. You're right. It's tough. But that will be an opening. Go on. Next question, please.
I'm a first responder. What is the best way to talk to a person in need of paramedic care?
Yeah. So first of all, thank you for your service. You're in the trenches, and you're doing what we used to say, that's God's work. That's really, really hard. So I imagine, I can't be sure, but I imagine, here, doing some active listening, I imagine you're talking about a situation in perhaps which you've come to somebody's home or someone's on the street, and you feel that they need attention. They need to be brought to the emergency room, and they're not willing to. And also, it's not like you have the luxury of the two of you sitting on comfortable couches in a psychotherapeutic situation. But even in those situations, use the leap techniques in a kind of a quick way. In other words, you assess the person, and then you say, "Tell me what do you think is going on? what is your what is your assessment of the situation? And they will say, nothing's going on. I'm fine. And you can sort of, again, and not contradict, but, agree with them. Say, okay, so you think that everything is fine. You think, I hear you. I hear that you're hoping that that's the case. But tell me what was going on, because I got called. How did that happen? How did I get called? What was the situation? Again, without trying to impose on them, what was the situation that got me here? And then that, again, will open up. That's the listening and the exchanging and trying to understand it from their perspective, trying to understand what was going on from their perspective. Tell me what you think happened here, and empathize with it. And once you have done that, you're in a better position to having an opening, to have them be able to listen to you as well. Now, I want to be clear. I was an emergency room psychiatrist, so I collaborated for many years, for decades. I worked with first responders bringing people in. I know how incredibly tough your job is, and it won't always work. And sometimes, you have to bring people in even if they don't want to come in, and sometimes you have to override them. But if you get to that point, I would just say, be clear that you are saying, I appreciate that you don't think this is necessary, but I'm worried about you. I'm worried that if I leave you here, something terrible could happen. And I'm worried about you. And based on my profession, I have the obligation to make sure that you get looked at, that you get maybe some treatment at this point. So if you can say that from prefacing it with the fact that the reason you're doing this is not to control them, but to care for them, So sometimes when you have to override somebody, couch it in those terms.
This question is from a patient. Many providers are apathetic to mental health disorders, and there's no extra effort to dig into what's really going on with the patient. How can I address this and build trust with my current physician?
So you are inverting the situation, and what I would say is you still have to use the leap technique on your clinician, right? You have to use the leap technique on your clinician. So I would say, let's assume it's a doc for a second, Dr. Smith, what's your experience with handling mental health issues? I know that you treat asthma, you treat all of these things. What is your experience with treating mental health issues? Is that an area that you're trained in or comfortable in doing? So open up the question to them. It may very well be that this is not an area that they're comfortable doing and that they have to refer you to somebody else. It may very well be that they can't do it. But rather than putting them on the defensive, recognize that this may not be in their purview. Now, again, at the Reach Institute, we've trained almost 10,000 primary care clinicians to be comfortable doing mental health issues. But that's only 10,000. So a lot of them are not. But if you, again, get into the partner mode, get out of the kind of conflict mode, get into the partner mode and say, are you comfortable? I think I have a mental health issue. I'm your patient. I wish you could treat me. Are you comfortable doing that? And then wait for the feedback and say, well, I'm not really comfortable doing that. I wish you would let me refer you out somewhere. Or the clinician could say, if they're really not comfortable and they really don't know about mental health, they may say to you, well, I'm your doc, and I don't think you have a problem. And then you have to say, well, respectfully, we disagree about that. And I wonder if there's someone you could refer to me for a second opinion, because it looks like we have a disagreement about that, and I need different kinds of help. I need further help.
This question is from a clinician. How do you communicate with parents who refuse to see that their child might be struggling with depressive symptoms, especially when the child is the client and as a provider, you have limited time with the parent. I can work with the child's needs, but then they go back to the same environment and their symptoms are triggered all over again.
Yeah. So again, those are the real challenges in pediatrics and pediatric care. And I just want to commend you for doing that work in those difficult situations. What I would say is, again, I sound like a broken record, but again, using the LEAP. First of all, abandon the idea that your job is to convince them. It's not going to work, because then you'll come into the meeting and it's like, I'm the expert. Let me explain to you what depression is. Rather, use the LEAP technique to understand their attitude towards mental health treatments. For example, they may be part of a religious community that believes that the only proper treatment for these things is a religious approach. So find that out. Find that out. That's very, very important. So the first step is to find out what their position is. Sorry, there was a fly here. To find out what their position is. Where are they? What is their experience? That's number one. Number two, compliment them. What's going on in your head is what in those situations is frustrating. And you feel like these parents aren't taking care of their kid. And that nonverbal gets communicated. And that causes space and distance between the two of you. So start out by saying, I know that you really care about Johnny. You are parents who really are trying to do the very, very best for Johnny. And I want you to know I am also trying to do the very best for Johnny. And I want us together to figure out, how we can do that. It sounds like we may have different ideas at the moment of what's the best. And I'm very respectful of your ideas. And I'm really respectful of your loving kindness, your parenting of him, and what a wonderful job you have done. I want us to work together. Tell me, what have you heard about depression? What's your ideas about it? What do you think about it? What are your worries about him getting that diagnosis, for example? So give them an opportunity to express and to you all of those ideas, all of their reservations. Everything where they're coming from. Now, this is not the situation in which the parents are being obviously abusive or something like that, and which needs other interventions. But it's a situation in which the parents are just negative about mental health or doubtful about mental health issues. Create that conversation. Create that conversation with them. And then sometimes it's not going to work, right? So, and then in situations where it doesn't work and where you find yourself for ethical reasons in conflict, I think it's very important to be open and sort of say, I'm a clinician, I have a certain responsibility. Yes, you're the parents, but I have certain responsibilities that I have to carry out. We're going to have to find a way to move forward around this, but I cannot let Johnny continue in this current state because it's a danger to him. So try the LEAP. If the LEAP fails, then be very open and transparent to them about the ethical conflict that you're in, and what your responsibilities might be as a clinician, even when it with respect goes against their wishes.
Someone who works at a crisis prevention center says, I like the idea that you have to understand your patient's pain, but that you don't have to feel it. But if you're truly empathetic, you do share their pain. Do you have any suggestions on how to understand it, but not feel it? Their pain?
Yes, I think it's a wonderful, wonderful question. And there's an old joke of somebody comes up to the street to somebody on the street in Manhattan and says, "How do you get to Carnegie Hall?" And the guy looks down at him and says, "Practice, young man. You've got to practice a lot." Right. So practice is so. What this technique of being able to be empathic without sharing the pain, without taking the pain on you, is a very important technique. You can learn it over time. I'm going to give you some hints in a moment, but I just want to frame it by saying it takes a little time. It takes a little time to do it, because when you're first faced with traumas and things like that, yes, you absolutely feel it when you first hear a story. When you're early on in your clinical training, you feel everything, and nor am I saying that you should not feel anything. One model that I try to use with people is what it's like when you are visiting a wake or a shiva, not of somebody that was close to you, but a friend's grandfather or something like that. You're coming there. You don't go in there boisterously. You don't go in there with a wrong attitude. You go in there with an empathic attitude, i.e., you share in the seriousness of the moment with them. But it's not your loss. You haven't lost a grandfather. You're not experiencing that loss. You're not experiencing that pain. But you are in the room with their pain. So think of it that way. Think of it. So step one. Yeah, let me try to do this in a kind of a more systematic way. Step one is let go of the idea that you won't be able to communicate empathy without having the feeling of empathy. Okay, let go of that. I think some of us come into the situation and say, if I don't feel it, I won't be able to communicate to them that I care. But you can. You can communicate to them that you care, even without feeling the full brunt of their trauma or their pain. You want to use your emotional radar, which is very strong, to get to understand what their pain is, to understand the details of their pain. But then you want to stop it from becoming your pain. And by the way, I would push back and say, letting their pain become your pain is in some way disrespectful. It's in some way disrespectful because it's not your pain, it's their pain. And you can't feel it the way. So I always tell my students and my trainees, never say, I understand how you feel. No, you don't. No, you don't. You're trying to, but you don't. A much better thing is, and a much closer to the truth, and one that sounds more empathic is, I can't imagine how you feel. I can't imagine how that feels. That is so awful. I can't even imagine how that feels. So recognizing that, which is that the other person is sitting there with pain, you are doing a full service by sitting there with understanding, but you don't have to sit there with pain. You have to sit there with understanding. And when I say understanding, not just understanding of their words, understanding of their feelings. But understanding feelings is not the same. Understanding feelings is not the same as having those feelings. Another example on this, because it's such a subtle and difficult point. What is the difference between someone who's had a trauma and has PTSD and someone who has had a trauma and doesn't have PTSD, has gotten over it and somehow is adjusted? The difference is that when the person who has PTSD remembers the trauma, they don't just remember the trauma. They don't just remember the feelings. They actually re-experience it, right? So someone with PTSD, you say, well, tell me what happened to you on 9/11. They start talking about it and they'll go into a panic. I've had patients, because I did a lot of that work, and I've had patients get up, run out of the room, and run so fast that I'm chasing them for 3 blocks before I catch up with them on Broadway, literally. Because they start re-experiencing it, right? Now, someone who's had trauma but has gotten over it, either they never had PTSD or they had their PTSD treated and cured, they will remember the trauma. They will remember the feeling, but they won't re-experience the feeling. So as a clinician, you want to be in that second place where you understand the trauma, you understand the pain, you understand the feeling, you know exactly what that feeling is, but you don't have to experience the feeling. You don't have to experience the feeling. And again, I think that you can let the patient understand that by saying, I can't imagine what that's like. I can't imagine what's that like, which means I'm not feeling it. I'm not feeling your pain. I'm trying to understand it at a deep level, but it's so profound. I can't imagine what that might feel like. I'm trying to. So I hope that clarifies, the different posture. And I will say that I think this is a point in training of a lot of confusion. I think that I got a lot of contradictory messages about this. And then suddenly around 2011, I was right in the middle of my career. I was suddenly thrust in the position of being a trauma therapist, which I hadn't been before. And so I treated lots of first responders coming out of 9/11 and heard some horrible stories, just horrible stories. I was fortunate to have a supervisor who supervised me and worked with this. And again, taught me this as a principal, and then was able to sit with me and we could go over examples and things like that. So I was actually able to practice this and be able to be empathic, communicate empathy, but not be in so much pain that I would burn out.
Well, that has to be the last question because we're out of time. But Dr. Amsel, thank you so much for joining us today and for sharing your expertise with our ADHD community.
Well, it's been my pleasure.
And I'd also like to let our listeners know that the Reach Institute has an upcoming course on this very topic, working with challenging depressed patients and their families. It's a 2-day course, September 30th to October 1st. Go to reachinstitute.org to register. And thank you to today's listeners. We hope to see you again next week. Make sure you don't miss future Attitude webinars, articles, or research updates by signing up to receive our free email newsletters at attitudemag.com/newsletters. If you're listening in replay or podcast mode, visit attitudemag.com and search podcast 471 to access the webinar resources, or simply click on the episode description wherever you stream your podcasts. If you support the work we're doing here at Attitude to strengthen the ADHD community, we encourage you to visit attitudemag.com/subscribe and sign up for Attitude Magazine. Thank you, everyone.
For more Attitude podcasts and information on living well with attention deficit, visit attitudemag.com. That's ADDITUDEMAG.com.